Welcome to this episode of 340 Banter. Today, Chelsea and I are joined by Jamie Kim, Vice President of Pharmacy Services at Legacy Community Health. We'll be discussing her implementation of a specialty pharmacy program at her health center and discussing how much it's impacted the patients in Texas. So, Jamie, I know you've really developed and then grew a specialty program at your health center. And that's, I think, new for a lot of health centers to get into that specialty space. So I'd really love to discuss that and discuss your experience with it and what you've seen from the program after you got it up and running.
Yeah, so I think initially we were just thinking of getting specialty accreditation through URAC because
just getting your
Yeah.
accreditation because that's such an easy feat.
because we had lots of HIV population, and we thought that eventually HIV medication will be exclusively specialty. So we thought we needed that accreditation. That's how we started. And then when we started to see that there are much more opportunities out there to add more drugs. And initially, because the HIV and PrEP injectables came out, and so we had to somehow launch this because our patients really wanted it and they really needed it. So we needed to find out ways to administer that drug in clinic and to get that contracts ready and how to build that business. And so that was kind of the start of it. And then I started to see that even though health centers, we treat majority primary care, there are a lot of disease states within the primary care that you really need to provide support. Things like osteoporosis, right? Like you don't really need to go to endocrinologists. Actually, if you empower our providers, they can prescribe these medications. And when they're actually in-house, their care is much better because once you send them to the specialty, that's when you actually lose them in access, right?
I think we noticed that a lot with the Hep C.
We did the same thing within our clinic is focused on provider training so that they felt more comfortable with it.
Yeah, and hepatitis C was big too because we realized that there were so many undiagnosed hepatitis C patients. And so how do we make sure that we're screening them? So we started putting in place for collaborative practice agreement for our pharmacists to see these patients. Yeah, and also
you have so much overlap with the HIV positive population too, with probably undiagnosed hepatitis C as
very
well.
high risk population. So, and then really teaching our providers and putting in EMR, clinical decision support, so that they can actually screen better. So our screening rate was less than 50%, and within months of implementation, it went above 80% of screening
Holy
rate.
cow.
Wow, that's
For all patients.
That's impressive.
Right. And so that was really exciting. And our providers were realizing that, wow, like we have a lot of patients that we haven't diagnosed. And then when you send them to the pharmacist, the clinical pharmacy specialists are doing a great job handling these patients. And the specialty team supports that. And our operation team supports that. So it was like a really big multidisciplinary effort, but we were coming together as a big team.
Synergy. I am not going to use that that term, but all those teams working together. And I think what I've noticed is at my health center, when we were trying to really get into the Hep C space and start screening those patients, is the medical providers were a little concerned because they didn't feel like they had the knowledge to do it. And having support of clinical pharmacy is a way to overcome that knowledge gap with the therapies.
Yeah.
So I think kind of if we go back to the logistics or the pharmacy logistics around, stepping into the specialty pharmacy world, because I think that's something that many health centers would love to be able to pursue, but it just seems insurmountable because, it doesn't fit with any of the current pharmacy initiatives within the health center. So can you talk us through logistically? You said you started with URAC accreditation. How long did that take, and what other resources did you have to pull in from within the organization? What did that look like?
So the URAC accreditation, I think how we did it, initially we had a little bit of help from a consultant to kind of learn how to set up the procedures first. And so they gave us some templates to work off, but then it's not really one fit for all, right? So when we looked at our health center, it wasn't really all that, just adaptable. So we had to customize a lot of those procedures. And so, it was a lot of paperwork. And I just actually went through 5.0 standard application like a few weeks ago. And that was crazy, right? Just reviewing all those procedures. But I think once you understand the concept behind why we're doing the accreditation, I think you're able to ensure that you're having all the procedures centered around the patient care and the access. And so I think we already had the processes already. It was just a matter of paper. Yeah, it's just writing out and spelling out, and then make sure that we are held accountable for each of those things. Like, for example, how do you send those medication and delivery? How do you package them? Like refrigerated items versus non-refrigerated. Those things we just had to really iron out the details. But once we've done it was no brainer because we already have those processes. We're already practicing it. It's just fine tuning some of those things on paper.
So who'd you have to have on your team for that? Pharmacy leadership, medical leadership, I assume financial leadership, compliance leadership.
Yeah, compliance had to really support us to make sure that everything that we were doing was correct. And then financial leadership to support us and to, pay for all these accreditation. And they asked us, like, why do you need this? And so we had to really explain that some of these payers would really look at us differently once we have that URAC accreditation. And once we start to really expand these types of medications, we would need to have these types of procedures in place to make sure that we are doing everything kosher. And so
not just the payers, but getting access to some of those drugs from the manufacturers, you need that URAC accreditation as well.
Like low distributed medications and things like that. So I think I'm really grateful because I think our leadership really trusted us and really supported us to start this process. And once we got it done, then we got to see, wow, like we have so many opportunities that we didn't know that we had, and really getting different access to medications. And I think one of the other ways that we tested a lot of the processes were actually our employee scripts. So we are like our own employer health benefits.
Self-insured.
Yeah. So we were we had our employees seeing our providers already. They're our patients. So really testing their prescriptions.
Well, and that's a great way to decrease healthcare costs for the employer.
Yes.
And you're keeping everything in-house where you can minimize the expense.
And so we initially had less than 30% capture rate on all of our employee scripts. But then we came up with an initiative that we will waive their copays if they used our pharmacy. And so they started all using our pharmacy. Now our capture rate is over 85%.
Wow, that's great. That's fantastic.
Yes, and it really helps. The employees actually feel it because when they come to our pharmacy, we provide this full service, right? Clinical pharmacies. They get to see our pharmacist and they know that it's going to be delivered to their house. And so everything is taken care of. So I think they're now really enjoying the service. And that's how we were able to test out some of the complicated drugs. And then we would actually expand that access to our actual patients too.
Your non-employee patients.
Yes, non-employee patients.
So what was that timeline like? So from the day that you guys were like, okay, we're going to start this, let's start the process of URAC accreditation. Was it a couple months? Was it a couple years? What did that look like?
No, I think URAC accreditation process only took us a couple of months, but
That's
I think
fast.
From what I've heard, it's typical. Most people I've talked to have said like 6 months or a year.
6 months to a year. Yeah, I think it was about probably 6 month time period because we were really trying to get this started because our HIV medication percentage was so huge and we didn't want to jeopardize
lose access.
Yeah, at that time. So we were really pushing for it. We all worked really hard, like sleepless nights. And so we did that. But I think really getting all of the specialty drugs to where we are today, I think that took us about good 5 years to really build up slowly, right? So it's not something that happens overnight.
I think that's an important point for a lot of health centers that are looking at this, that are in the challenging financial times that we're in now, looking at specialty pharmacy as an opportunity to better serve their patient population, but also better financially support their organization, knowing that this is a long-term endeavor,
Yeah.
and it falls under the guise of you have to spend money to make money, and it takes some time to build up to that. Is important to know.
And I think it's important to really target each disease state separately. But at first, we were kind of naive, right? So when we did the whole HIV and PrEP and jumped into these injectables, we thought, oh, we just start and we just administer and we'll get paid. But that was not the case. We actually lost a lot of money at the beginning when we started that injectable, because you actually have to build both pharmacy side and medical billing. And in the health center space, the medical billing side on these high cost drugs are not something that we're used to doing, right? And so
We're typically used to the lower cost drugs that fall under that prospective payment system. Everything's all
Bundled
up.
Yeah.
And it doesn't matter, right?
Yeah.
And so we get paid a little bit more probably. So we were able to compensate that before. But now we're talking about thousands of dollars of drugs in each administration. And we
make
were
sure
not
you do it
used
right.
to that. And so we went from Athena Practice to Epic. And so that transition was very difficult too. And so you worked with like two different systems. At first, we worked with Athena. We didn't have everything on there to actually bill correctly. And then we moved to Epic, but we still needed to make sure that we were collecting all those money. And so it was all like probably months and months of all of us working together, RCM, pharmacy, medical leadership. We were all working together to ensure that we have everything built correctly clinically to build, and then make sure that your prior authorization documents were attached correctly, right? Your referrals and, prior authorization, actual authorized number had to be attached to that order correctly all the way throughout the whole process. And we are doing it in a timely manner, but then also dropping the charges correctly, collecting them. So that was a lot of work that we had to do to refine that workflow and to ensure that we're collecting everything. So that took us months to figure out. And then once we did that, when you figure out one drug correctly, then now adding other drugs becomes easier. And so we actually put it in timeline for the last year to really go and add more disease states. That's when we started putting in HIV-associated metabolic disease, osteoporosis, even hyperlipidemia, those drugs. And we started to expand our collaborative practice agreement and different disease states and also guidelines.
I think that's definitely a great point, is don't bite off too much at the beginning. Make sure that you can support what you're doing. And I think a lot of health centers where they're struggling right now thinking about specialty is they're not in the place where you were with the large HIV population, where they're worried they may not have the drugs to support a specialty pharmacy. So what is there any advice you can give those health centers that are more focused on primary care, what you've seen as far as the non-HIV treatments?
So even if you don't have a lot of HIV population, I think there's definitely a room for PrEP. Right? Prevention of HIV is definitely, that's for everybody, right? And I'm really trying to go out there to work with schools and different, organizations.
Community foundations
Yeah,
and things.
to test them. And then you have a lot of opportunities to add that. And then
These
hepatitis
long-term
C.
injectables are amazing too.
Yes. And now we have every 6-month injection came out. So there are a lot of options for these young people to be more convenient prevention treatments, right? And so there are, I think, lots of opportunities there. Definitely hepatitis C and even osteoporosis. As the patients are getting older, the Medicare population, there are a lot of chronic disease states that we can definitely expand, and with the help of pharmacists, I think, and I cannot emphasize enough of the value of our clinical pharmacy specialists who are able to develop these guidelines, provide education to our providers to empower them, and then support them behind the scenes, right? And to see them, see the patients directly, that will really go a long way.
I think, having the pharmacist there is so wonderful just for the health center in general. And I think that, you spoke to, your employees really seeing the value and the benefit of the pharmacy being able to get the whole experience, and just having the pharmacists embedded within the clinic or connected within the clinic empowers your prescribers, your providers to be more on top of the latest data behind the different medications. And then if there are any challenges with prescriptions, they're typically dealt with much more quickly because the pharmacist and provider already have a relationship where they can go and have a dose change. You can have collaborative practice agreements for things. So I think in general, the experience of the patient is much different, as well as for the prescribers and the pharmacists, because they're able to navigate challenging situations with much more ease.
Yeah, and maximizing the utilization of the EMR, right? So now we have a lot of good clinical decision supports, and so you can create smart tags or order sets and things like that, and that really helps our providers.
You mentioned earlier prior authorizations, and I think that that's somewhere where a lot of health centers struggle. And I think ultimately, if you're getting into the specialty space, this is probably the thing you need to shore up before you get in. So maybe tell us a little bit about how your prior authorizations are handled in your health center and how you've wrapped that in.
So we actually created a unique team called Medication Adherence and Access Team, and they are actually a little bit more experienced technicians, and they're delegates of our providers. So initially, that team really started to renew prescriptions. Once the refills run out, then sometimes you have this gap, right? Because the patient has not seen the provider yet, or they didn't get the labs, and so they're gonna run out of refills. And until the next visit, they don't have the medications on hand. So what we've done is we created a protocol where under the doctor's provision, these technicians can actually add in another refill for the patient until they see the provider, and they can actually make an appointment for the provider. So we created this
not unlike what MAs do from
Yes.
providers in most instances.
Yes, but we created a centralized team that could support our whole organization to do that, and that really increased the efficiency of our providers and MA time.
And being pharmacy technicians, I love because they speak the language. I
Yes.
don't know how many times I sent a prior authorization to an MA and they were trying to help, but they'd call and they say, well, the prior authorization is not required. Well, it's not on the drug, but it maybe is on the frequency or the direction. So having the technician there, they speak that language.
Yeah, and they are really equipped to do this job of bridging the gap.
And it also creates a career ladder for an area that often lacks that.
Yeah.
And so that really gave them the empowerment, and also I think the joy of moving up to another realm of pharmacy world. And as we were doing that, we started to have them specialize in prior authorization. So it's a centralized model. So once our pharmacists need a prior authorization, then they send that message over to this team, and then they take over from that. And a lot of these drugs, because we develop clinical guidelines, we actually created smart text for our providers to add when they're seeing the patient. So all of the clinical criteria are already built in your EMR record.
That's great.
So then the technician just needs to pull that and then just send it over. So the process is seamless, right? They don't have to really dig in, look for all these clinical criteria to send in for prior authorization. Everything is
It's in
one
one
document.
place.
Yes.
Yeah.
And so that made so much easier. So every time we find a complex disease state, that's when we pull back and actually develop these types of smart texts.
That's great. And I think that probably from your medical and nursing teams are probably thrilled to give that up because no one likes prior authorizations. But
everybody hates that part of the job, right?
Yes, but what I've seen, and I've seen this in other health centers, that they're starting to have technicians handle the prior authorizations, and technicians actually they're good at it, and they actually enjoy the work.
Yes.
And they understand the impact of it.
And I think really what we've done is trying to really have all of our staff really practice at the top of their license. And how do we do that? To empower them, because they're more than capable of doing, just dispensing, right? So even our pharmacists on the floor, we've given them a prep program. So they're actually handling the whole prep program on their own. They're swabbing the patients, ordering labs, they can prescribe, and even osteoporosis and all of these injections, they're able to inject themselves. And so they're like Yeah, they're taking over in between visits from providers. So if the patients are seeing them only, once or twice a year, the pharmacists and technicians are, bridging all the gaps in between. And so it's very exciting for them to be participating in this type of program.
Jamie, it's been super wonderful to speak with you today. And I really like that we have some kind of tips and tricks for success for health centers that might be looking at the specialty pharmacy realm and things that they can do in-house to maybe work themselves up to that point. Thank you so much for meeting with us today and sharing all that.
Yeah, thank you.
You're very welcome.